Good afternoon, all my esteemed panelist colleagues, a lot of other friends across the globe. We are part of the third scientific summit on tobacco harm reduction, novel products research and policy. And this session that we have is on tobacco harm reduction in low and middle income countries. And I'm trying to look at the details of the panelists that I have the pleasure of being with, and it's unbelievable. We have a dental surgeon, we have an oncosurgeon, we have a pulmonologist and addiction specialist, we have a molecular biologist, we have a medical technologist, and we have a medical doctor who is into health professional leadership besides a health manager. And so those are the seven unbelievably diverse disciplines that we have here represented. We have friends from Indonesia, Malaysia, Tunisia, South Africa, Costa Rica, Philippines, and of course, India. And so that's the diverse set of panelists that the organizers have put together. And I must say very briefly, must individually thank the organizers and everyone else involved for asking me to be here. Uh, Secondly, thank you for arranging such a good panel here. A moderator or a chairperson is essentially supposed to be seen and not heard. The speaking part is the prerogative of the speakers and the panelists. And so I'm going to try and stick to that, except for this half a minute of introductory remark and possibly the last 15 minutes of the hour to try and see if we have question answer from our participants or discussion amongst the panelists. So without further ado, let me get to the first panelist, and that is Amaliya, who is a dental surgeon from Indonesia, a hugely experienced dental and periodontology expert, specifically interested in nutrition, oral health, and tobacco harm reduction. Can I just remind all seven of us, please, that the organizers have set 6 minutes for each panelist. And so in other contexts, a moderator or a chairperson is essentially a timekeeper. It's a not so pleasant task of keeping to time. And so you'll all please forgive me in advance if I need to remind you at the end of 6 minutes about the time. And as the organizers told us, we will all go mute when the other person is presenting. And I'll do that first. Amaliya, please.
Thank you, Dr. Desai, for this opportunity. I thank you for the committee to inviting me for this session. And unfortunately, I don't have my slides, but I would like to briefly speaking about the progress of tobacco harm reduction, especially in Indonesia. Well, in 2012, it's generally introduced to Indonesia, the e-cigarette, and it is like an not a legal status or condition because it's very new and nobody knows about tobacco harm reduction principle. So everybody just like saying that this is as harmful as conventional tobacco products. And in 2017, I think that the government said that for importer to have the e-cigarette liquid or device, they have to make regulation and also lot of rules to make it come to Indonesia. But then in 2018, the tax or the excise is given for a cigarette, and it makes the legal condition for e-cigarette in Indonesia. And then in 2020, the regulation is easier that the government just say that for imported e-cigarette and liquid, you just have to give the identification number for importer. So it's okay, and it's in the scope of imported electronic device. So I think it's easier for Indonesian to have all of the devices, and also for illiquid, it is a legal, have a legal aspect and legal condition to be produced in Indonesia. But then we also have strong resistances, especially from health authorities, and also lots of misleading information, lots of false or hoax that say that it is as harmful as conventional or tobacco products. And also the health authorities' decision um, is based from WHO stance. So if they hear from the WHO that it is okay, then the health authorities in Indonesia say it's okay. But until up to now, it's still a strong rejection, strong resistances from health authorities. But I think that in the long run, maybe it will be unenlightening. And also, we have advocate the government to have the evidence-based regulation, because it's really scarce in Indonesian to have evidence-based regulation. We already provide the government with recent result from literature and also from studies throughout the world from the expert. But still, we have strong resistance for this tobacco harm reduction. But then, when we have an analog from maybe harm reduction from drugs or free sexual habit, then maybe they will accept this as really a harm reduction principle. So we really have to make a connection with this condition. And I'm quite sure in the long run we will get there, but still long way to get there, and I still have hard work, but I know I'm not working alone. I think it's the condition that reflect all of the tobacco harm reduction condition in Indonesia. Still strong resistances and still lots of misleading information. Dr. Nimesh?
So much.
Yeah.
Amaliya, thank you.
Thank you.
Thank you so much. Can we then
You're
go to
welcome.
our, thank you so much, really, that was nice. Can we go to then our next panelist from Costa Rica, who is the Chief of Surgical Oncology and the Chief Medical Officer at the local university in Costa Rica, San Jose. Efrain Cambronero, is that right, Efrain? Am I all right? No offense, sorry. Efrain, please.
Okay, got it. Yeah. Can you hear me? Can you hear me now?
Yes, please.
All right. Thank you, Dr. Desai. Yeah, you got my name right. Yes, perfect. You know, by listening to the different talks on the tobacco harm reduction during the whole meeting, I realized that Latin America, and particularly Costa Rica, is lagging behind, on this concept. And I think, for the low and middle income countries, I think, this can be an important measure to implement in order to decrease, the morbidity and mortality. 80% of smokers actually are in our countries. And as you know, if this tobacco epidemic continues during the 21st century, 1 billion deaths from diseases related to tobacco are expected. So I think it's important then to start engaging actively in the concept of tobacco harm reduction. Also, obviously, this needs to be an integral part of a more comprehensive tobacco control. And, and one of the things that are really um, is very worrisome for our countries is that all these uh, diseases and deaths, represent a, a staggering healthcare expenditures. In 2012, the healthcare expenditure due to smoking attributable to diseases total a $422 billion globally. And if loss of productivity due to smoking attributable illnesses and deaths are taken into account, this cost is estimated to be as high as $1,436 billion, with almost 40% of this cost incurred in low and middle income countries. Therefore, reducing tobacco consumption through the implementation of a comprehensive tobacco control measure and tobacco harm reduction alternative really ensure large savings for our countries, as well as benefit the population in general. No doubt, the most effective action that will reduce all tobacco-related morbidity and mortality is prevention and complete smoking cessation. But in the real world, we know that quitting smoking has been, it's extremely difficult. 3 to 5% success rate at 5 years using the approved nicotine replacement therapy, and up to 20-25% when FDA-approved non-nicotine containing drugs such as bupropion or varenicline and counseling are used together. Therefore, implementing more, and more importantly, maintaining long-term tobacco control around the world is a monumental, expensive, but necessary task. Harm reduction, which by definition is a public health strategy aimed at reducing the tobacco morbidity and mortality without necessarily eliminating completely the exposure to tobacco-emitting toxins, may be more realistic alternative than just trying to wipe out smoking from the face of the earth. Use of non-combustible tobacco products such as ends or heated tobacco products might be less hazardous to public health than combustible tobacco. Thus, integrating this option with a comprehensive tobacco control program may help to decrease the many diseases related to tobacco use. However, the World Health Organization stance is against tobacco harm reduction, namely e-cigarettes and heated tobacco products. And it does not appear to that position is going to be changed anytime soon. Costa Rica has very strong ties with the WHO and the Pan American Health Organization. The country was among the first that actually signed the Framework Convention on Tobacco Control and implemented and enforced all the tobacco regulations encompassed with it. Currently, e-cigarettes, which there's an estimated 1.6% of consumers of e-cigarettes in the country, are commercialized and regulated under the same conditions as combustible cigarettes. And as we speak, actually, there is a new taxation being discussed at our National Assembly. So I firmly believe that developing countries can benefit most from a tobacco harm reduction program based on e-cigarettes, as long as they are regulated and as a part of a comprehensive national tobacco control program focused on preventing minors from getting access to tobacco products, and also the cessation programs to help smokers quit for good. We need to remember again that 80% of smokers are from our countries, and so are hardcore and hardened smokers, who are those smokers unwilling or unable to quit. Therefore, implementing tobacco harm reduction approaches at population levels in our countries, although does not seem to be, something that is going to happen in the short run, I think we need to start, actively engaging and trying to spread the concept among our colleagues. Actually, I have implemented it in my day-to-day practice. So in summary, for those hardcore smokers, which according to the Global Adult Tobacco Survey account for up to 38% of current smokers in low and middle income countries, tobacco harm reduction programs may help to save lives among them. And for a tobacco harm reduction program to be successful at benefiting public health, it needs to reach some kind of equipoise, reducing morbidity and mortality among smokers on one hand, and averting addiction of new generations on the other hand. Thank you very much.
Thank you. Thank you so much, Efrain. That was very concise and nice. May I now go to invite Professor Sharifa from Malaysia. She is a professor of hospital management and health economics. Madam Sharifa, please.
Thank you very much, Mr. Chairman.
Yes.
I just want to touch on Malaysia's, some of the experience that we have in Malaysia. I have only 3 slides, don't worry, it's not going to be very long. And we have a very big problem of tobacco or combustible tobacco issue in Malaysia. Almost in one of the earlier surveys mentioned that almost 50% of the male more than 12 years old are smoking. But of course, that has reduced so much, and our latest National Health and Mobility surveys shows that the tobacco has basically reduced and basically only about 21.3%. And from the total smokers and the prevalence of e-cigarettes is about 5%. We don't know how many are actually using IQOS and things like that. But the other problem is that we have a huge market. Well, basically our price of tobacco, because of we want to deter tobacco use, we start to increase the tax and also the price of tobacco. So Malaysia is basically the 3rd in Asia to have the highest price of tobacco in Asia. And because we think because of that, we also have an influx of a lot of contraband and also illegal cigarettes taking over the market. And because of that, we lose about excise of about 3 billion per year due to this contraband and illegal cigarettes. So the market for contraband is very high in Malaysia as well. Now, the issue is that people access to tobacco is very easy because of the contraband, but also they access the regularly sold tobacco products or combustible tobacco in the shops and market. So we have a huge burden of non-communicable disease led by cardiovascular, diabetics, or stroke and things like that. And the amount spent to actually cater for this treatment and management is actually huge in Malaysia. So Malaysia also targets that we want to have fewer smokers by 2025, and this is very much led by our Ministry of Health, who have actually dwindled on the new Tobacco Control Act, likely to be out. We're not really sure when. It was mentioned that it was going to come out last year, but now it is still pending. I'm sure it's going to come out soon, where the proposal is to actually ban everything, not only tobacco, but more stricter rules, but also e-cigarettes and also other products like heat not burn products. The issue is that once we have that, we are not going to have an option for the consumers. And because of that, we are, in a way, I see that we are going to propose that a lot of cigarettes, they don't have an option and they are going to continue smoking cigarettes. This especially is for the hardcore smokers and people who are not able to actually quit using NRT. So in Malaysia, tobacco harm reduction is relatively new. We have a few concepts of harm reduction, things like methadone, replacement therapy, and also needle exchange program. But things for tobacco, the harm reduction concept is not very well received. It goes throughout all levels, as example for Ministry of Health and so on. So most of these actually have a huge intolerance for harm reduction for tobacco. And some of the other alternative that has been proposed, and this has been mentioned correctly by some of my friends, but in Malaysia, we see that for nicotine replacement therapies, things like gums, patches, and so forth, the treatment, these are seen as less efficient. And we have seen from the papers inside Malaysia that success rate and also the failure rates differ by states in Malaysia as well. So in a way, it is not standardizedly implemented throughout the whole country due to access issues and also pricing. Some other things like electronic cigarettes and ends, it is huge market in Malaysia. We have some laws and regulation, things like if you are selling juice with nicotine, it's not supposed to be sold in the market. It has to be seen through a pharmaceutical or medical personnel. However, again, like the issues of tobacco and cigarettes, we also have huge influx of all these, contraband or basically small enterprise electronic cigarettes using e-juice that has not been controlled, the concentration and also the concentration of nicotine inside the juice, or whether there's any tainted with microorganism or fungi and things like that. And because of that, we see a huge number of electronic cigarettes are not being actually curtailed in the market. And we are very worried because of not only the problems of dual users, people are using tobacco, but at the same time, they're trying to quit. So they are also hooked on e-cigarettes and also the nicotine inside there. But in our country, it is also seen negatively as an introducer to tobacco smoking for young population. And this is one of the hindrance of tobacco harm reduction in our country. The ends regulation, like I mentioned, some of them are present. It is a bit haphazard. The nicotine are not supposed to be sold, but we can see here and there, but also online, there is still products of vape and also e-cigarette being sold. And once this is actually not being maintained properly or actually without regulation, this is being abused by the public, and we see that this causes a problems of harm reduction furthermore. So there's no proper monitoring of use, and there's no actually proper therapy of switching, and of course, and whether they are being followed by absolute maintenance, abstinence from tobacco. So these are some of the problems that we see in our country. I don't foresee that the harm reduction is very well being taken in Malaysia, and we are very much obliged with the WHO, FCTC, as what has been mentioned before by our previous speaker. So once WHO actually closed the door and it is not being seen as an alternative to actually quit smoking, and this would be very much helpful especially for the hardcore smokers in our country. Thank you very much.
Thank you so much, Professor Sharifa. That was very nice with these slides and in time. And we now have Dr. From South Africa, our friend from South Africa, with Nelson Mandela. How nice. We have Dr. Kgosi, who is a medical doctor, I understand, and a leader of the health professionals. And so he's the president of the Health Professionals Council in South Africa. Dr. Kgosi, please, all yours.
Thank you very much, and greetings to all in the panel. Africa is in a difficult state in that most times we're dependent on the WHO in terms of guidance on health matters. The FCTC has been in existence for quite some time. And what amazes me is that when you look at the FCTC, it is all a harm reduction strategy. All the things that are contained in the FCTC are aimed at reducing harm from combustible tobacco. Marketing restrictions where you can use cigarettes, health warnings, all those are harm reduction strategies to reduce harm and to help people understand the dangers of tobacco. The starting point will always be smoking is bad for your health. Quit if you can. But we're aware that we have 1 billion smokers around the globe, people who either cannot quit or are happy with the habit that they have. Now, the problem is that because of the history of the tobacco industry, the FCTC has come out in a prescriptive manner. Thou shalt not. But if you look at, as a physician, we no longer prescribe to patients. We no longer think we are the next best thing next to God. And it's no longer take this 3 times a day and come back to see me. Patients are now more informed. They engage. We inform them. We give them options for treatment. We give them all the information that is available. And we can even make a recommendation. But we are facilitators. we are helping them get better, and we give professional advice. But if you look at our attitudes in terms of tobacco, they are still prescriptive. They are still directed by the fact that smoking is considered a sin. Most countries have a sin tax, and our attitudes are the same. Now, part of the issues that have bedeviled harm reduction is one, that stance where people are informed by ideology. They are ignorant on facts, but they're informed by ideology. I have fellow physicians that advise patients around smoking and smoking cessation. They don't know what an e-cigarette looks like. They've never heard of heat not burn. They've never heard of the differences between combusting tobacco and non-combustible delivery of nicotine. But they will be quick to prescribe, not even to advise. So they are informed by ignorance in combination with ideology and having opinions without informing themselves. So we have a great duty in terms of informing not just the patients, but we also have to inform the public and educate healthcare professionals around alcohol. The other significant issue is the abuse of the precautionary principle and using youth uptake as the excuse. Remember, harm reduction is about those that can quit, those that are using something that will harm them. And I understand not inducing uptake from youth, whether it's a combustible cigarette or an alternative to combustion. Now, the other issue in terms of harm reduction that harms harm reduction is harmful communication, where people are either not telling the truth or they distort information. If you look at what happened with EVALI, the electronic vaping associated lung injury, it was misrepresented as being caused by nicotine. And it's always easy to come up with false information and cause damage. There's never enough effort to correct harmful communication. And after that harmful communication, the perceptions of the dangers of less harmful products worsened. It increased by 15 percentage points in the US. So I think the great duty is the duty to educate. It's to ensure that we have evidence-based regulation and to ensure that the WHO, which promotes science during times of COVID, should also be open to evidence-based regulation. Now, if you look at it, the FCTC mentions harm reduction, but it was a byline. And at the time that the FCTC was proclaimed, there were no real alternatives to combustible cigarettes. The only thing that had been there was smokeless tobacco, which was also misrepresented. Snus was banned in the EU countries, and it's still banned in most of them, except in Norway and in Sweden. It was allowed in Sweden, but if you look at the evidence about harm from snus compared to harm from combustion, the evidence is clear, and it's been published by the WHO itself. But they are still stuck in the mode of not telling the truth about less harm if you do not combust tobacco. Less harm if you get your nicotine from elsewhere. I mean, nicotine replacement therapy is accepted everywhere. It's a medicalized solution that is accepted. Now, if you have alternatives that provide nicotine over the counter, why does nicotine now not become acceptable? But when we use it as a therapy in the practice of medicine, it is acceptable. And I think we need to be frank, we need to be open, and we need to discuss. In South Africa, our Tobacco Control Act is being reviewed. And what we're urging the ministry is that they need to be able to take evidence into account. People need to understand that combustion is the problem. There are less harmful products, and we need a different legislative framework that recognizes not all smoke is the same, and we need differential regulation for products that produce less harm and offer a respite for smokers. Smokers are humans, smokers matter. And I will end there, sir.
Thank you so much, Dr. Kgosi. That was very nice. And next we have a pulmonologist who has also specialized in addiction treatment from Mayo Clinic, and he's the chairman of the Tunisian Society of Tobaccology and Addictive Behaviors. A great pleasure in introducing, ladies and gentlemen, Faris Mili, a pulmonologist, specialist in addiction behavior, tobacco control, and tobacco harm reduction activist. Faris, please.
Yes, I'm here, but I don't see myself. I have no video image.
I think it has been closed by the organizers.
Yes.
I think organizers have to open it. I think it is Dr. Faris Mili has to come online, not me.
Yes, sir. Faris needs to come online. But if you'd like, we can go to Rajesh first and then come back to Faris. Shall we do that?
Okay.
Yeah, why not? Okay. To take a bit of a turn, we'll come back to Faris Mili. My compatriot from India and my good friend for a long time, Dr. Rajesh, molecular biologist, tobacco harm reduction and tobacco reduction activist. Rajesh, please, all yours.
Thank you very much. It's a great pleasure also for me to join this very, very special panelist and audience, and especially chaired by my friend Desai. So this is wonderful. I hope I have my slide shared, and I hope you can see. So I will try to keep it to 6 minutes. So I have this perception from India, and as you know, reasons are obvious that the global burden of tobacco, which stands actually 1.3 billion now as per the latest WHO records, the major chunk of this is naturally on LMIC, 80% of it, so over a billion tobacco users are in LMIC. All of us are victims. And we know that 8 million people die annually from this every year. And if you look at the projection, this went fast. The projection, there are active users and bystander. That means basically it refers to the smoking part. What is very worrying for me is the projection on death, cumulative death from 2005 to 2030, so next decade for us, where the LMIC is going to have the huge burden of 135 million deaths as compared to high income groups, which are less. So what basically tells us that the LMIC is actually bear the brunt of most, even though West also suffers. And one of the reasons that is very typical for India, but I think it applies to many LMICs, is that tobacco landscape, which is so wide that almost everyone gets naturally attracted and induced into this habit, starting from cigarettes of various types and sizes, with filter, without filter, to BD, something very typical for India, in various forms and with various kind of flavors. Then we have large types of homemade devices to consume tobacco, burn tobacco. And those who don't like to, because it's a taboo in many parts of India, they have options to use the smokeless variety, where also you start from betel nut, quid, and in my opinion, that's the gateway to tobacco. And then you have a huge variety to meet every taste, every kind of economic status, and so on, bringing it to a very large number. And that's why India has almost 300 million tobacco users. Now, what I thought that we'll have a reality check, look at the roadblocks and see what can be done. Perhaps for India, but may apply to many, at least Southeast Asian countries and many LMICs. Now, India has committed under FCTC that it will reduce tobacco burden in India by 15% at the end of this year, so in next few months. So in December 2020, it should be less reduced by 15%. And in next 5 years, 2025, it should be reduced by 30%. But the reality is very different. We legislated FCTC provisions into law in India. We call it KOTPA, way back in 2003, so more than 1.5 decades back, and applied it. So you know the usual FCTC measures that are applied. And we do see visibly less smokers, particularly in urban areas, reduction in tobacco prevalence in adults by 6 percentage points, and similar in among young people, the minors. We have increased age of initiation, which is fantastic. And we have almost only about 50% people who ever thought of quitting, and very poor outcome, because the outcome is nearly 5 to 7%, as you all know. So what are the roadblocks? Why we are unlikely to meet the targets that India? Because the roadblocks, as I see, is inadequate, inefficient, and poorly funded and trained tobacco cessation centers and quitline services in India. For India, which has 300 million tobacco users, we have 19 tobacco cessation centers. So virtually one tobacco cessation center for 15 million or more tobacco users. That's a huge, huge burden. And when it's so crowded, supposed to be, I think it's least available to women and disadvantaged group of population. We have one quit line in India, and that makes works 6 days a week and 12 hours a day, which means it has a limited access to people. NRTs are very limited in India and also very expensive for majority. And therefore, we have very, very poor outcome of whatever efforts that go on. The second roadblock that I see in my country, and may apply to many other countries, LMICs particularly, is poor to nil implementation of this KOTPA Act in my country. For example, on the right side, you will see a typical street corner store in most small towns and cities and villages across India, even though most states in India have banned smokeless tobacco. And you will find that these hanging sachets present it in a great variety to meet all tastes. So there is a glaring policy and practice gap in India. Multiple reasons are there for, some justified, some not. There are socio-cultural issues, economic and livelihood issues associated with it, lack of public awareness and support systems, bureaucratic red tapeism, and unwarranted or tacit industrial interference are very obvious. And to some extent, lack of political will as well. So what can be done? I mean, we have to not only discuss the problem, but also look at solutions. So I look at two solutions based on our own study, which are published and given here in reference in this year, in last few months. The first action point, in my opinion, is the strengthening the concept of tobacco harm reduction among people, healthcare providers, and policymakers. That's very, very poor in the country. and we must enhance availability and portfolio of NRTs and reduced harm products as an alternative to smoking. As many panelists already said, that limited availability of NRTs and reduced harm products are a big impedance to reducing the tobacco burden. For instance, India, which has very small electronic cigarette users, as per our GATS study, it's less than 0.2 million. So very small compared to 300 million tobacco users. 0.2% million is very small. But even then it was banned, so another possible avenue was closed. And our study, as you can see on the right side, shows, published earlier this year, shows very different pictures, appearing that the policymakers had no idea of research that is in this field. Action point 2, and my last point, is urgent and appropriate efforts to upgrade knowledge, attitude, and practice of all healthcare providers for offering tobacco cessation service. That's very poor in our country. And our study, which was published just a few months back, referred to here on the right side, shows that there is a huge nicotine illiteracy among healthcare providers. 70 to 90% of healthcare providers in different categories believe that nicotine is a carcinogen, which is not the fact. And they had no idea that tobacco had other carcinogens. So there is a problem there. We also have significant deficiency in tobacco-specific training to these clinicians. As you can see, 20 to 30% clinicians had any idea of how to treat tobacco, offer tobacco cessation services. And I think we need, and all of them were very motivated to acquire this knowledge. So we need these two actions. If we do, tobacco harm reduction is a long goal. It cannot happen overnight or in 1 or 2 years. But if we take these 2 points, it will make a lot of difference to the world. Thank you very much for your time and for your.
Thank you so much, Rajesh. Thank you so much, Dr. Rajesh. We now have opportunity to go back to our friend Fares Mili from Tunis. Yeah. Can we have Dr. Fares Mili, the pulmonologist, addiction treatment specialist? We have the opportunity to go back to Dr. Fares Mili from Tunisia.
Hello, do you hear me?
Great. Perfect.
Okay.
Sounds good.
First of all, I would like to thank all the organizing staff for inviting me to be part of this panel, where eminent experts from different countries are present. I would have 3 or 4 points to emphasize. First of all, we know that during this century, 1 billion smokers will die prematurely because of their smoking if nothing is done to change this data. 80% will be low and middle income countries. In Tunisia, smoking is a real problem with an overall prevalence of 25%. 1 in 2 men is a smoker. 1 in 4 young people is a smoker, and female prevalence is clearly increasing, reaching up to 20% in the capital Tunis. The National Tobacco Control Program has not achieved any of its objectives for several years. Those in charge of this program follow the WHO recommendations and try to implement the Empower program with great difficulty. Our efforts at the head of the Tunisian Society of Tobaccology and Addictive Behaviors consist in reframing the problem of smoking to consider it as addictive behavior and not just consumption of toxic substances harmful to the health of individuals and society. Last October, we succeeded in opposing an attempt to ban electronic cigarettes following the Ivali syndrome that occurred in the USA, following a decision taken at the EMRO, the WHO's Eastern Mediterranean Regional Office, and which wanted to put pressure on countries that have not yet regulated electronic cigarettes to ban them. As a member of the National Tobacco Control Committee, I was able to demonstrate by evidence that Ivali syndrome was due to consuming adulterated THC products and not nicotine products, and that it was absolutely necessary to get out of the black market. There is real hope now that reduced risk products could be regulated in the near future in Tunisia. Second point, I think that the role of scientific societies in promoting harm reduction in low and middle income countries is essential. Thus, we were able to rally to our cause several scientific societies, such Cardiology and Cardiovascular Surgery Society, Addiction Society, Medical Oncology Society, and Medical Sciences Society. In the coming weeks, we will be issuing a joint statement on harm reduction and low-risk tobacco products. Thus, the regulatory authorities will be able to benefit from scientific support for the decisions they will take. Another point, as Tunisian Society of Tobaccology and Addictive Behaviors in 2018, we established a cooperation protocol with the INEAS, the National Authority for Assessment and Accreditation in Health Care. We have confirmation now that in the coming weeks, we will begin developing the recommendations and the guideline for the treatment for tobacco dependence. The positioning of smoking as an addictive behavior, the place of harm reduction and reduced risk products will certainly figure there. The guideline will be authoritative for health professionals and for decision-making and health insurance authorities. Last point, I would like to end by recalling that smoking, like all addictions, causes cerebral dysfunction with impaired executive functions, leading to great difficulties during attempts to quit. The tobacco user, in wanting to change his behavior, has to deal with problems of self-confidence, of self-esteem, and feelings of self-efficacy. These problems cannot be solved by drug therapy. Only cognitive, behavioral, and emotional therapies are able to help smokers on these different subjects and to prevent relapses. These therapies are not always given, and smokers are not always ready to continue them. It's becoming evident that harm reduction is essential and an adoctological requirement and not as an additional choice of consumption for smokers. This is imperative in low and middle income countries. Scientific societies have a major role to play in guiding and putting pressure on regulatory authorities in order to include harm reduction strategies alongside traditional anti-smoking methods. And thank you very much.
Thank you. Thank you so much, Ferris. And we have the last of the panelists, Ron Sison from Philippines, who is a medical technologist. He is the lead convener of the Harm Reduction Alliance of Philippines. Ron, please. All yours.
A pleasant day to everyone. Tobacco harm reduction is even more called now among the in and middle income countries. The health and economic burdens of smoking-related diseases hit the people in these countries, which includes my country, the Philippines. The impact is therefore disproportionate to the poorest of the poor and thus require our immediate attention. In my country, the Philippines, some 16.6 million adults currently smoke, and that is almost 80% of current smokers plan to or were thinking about quitting. However, only 4% of those who smoked in the past year are able to successfully quit. This simply shows that the current approach in the Philippines to arrest the problem is inadequate. The Philippines, my country, as well as other countries that are similarly situated, need to reevaluate the strategy in controlling cigarette smoking. The first step is to have a science based approach towards regulation. Prohibition will just not work, and the half baked regulatory regime or an overly strict system will also do more harm than good. This has to be a good balance in providing access to less harmful alternatives to adult smokers and ensuring that minors can access them. And this is admittedly tough, and this is very much possible. As for the updates on the regulatory bill on the following issues in my country, the Philippine Congress here in my country, that since 2015, several bills have been filed on both houses of the Philippine Congress and that are sought to regulate electronic cigarettes and heated tobacco products or HTCs. Earlier this year, 2020, a Philippine tax law was passed, which also granted jurisdiction to the Philippine Food and Drug Administration over e-cigarettes and HTPs. The FDA, the Philippine FDA, has issued draft guidelines for the regulation of our products category, and they are holding public hearing that are scheduled to end of this month. The Joint House Committees on Trade and Industry and the Philippine Health approved a substitute bill last month that aims to regulate the electronic cigarettes and heated tobacco products or HTCs. This bill highlights a policy to consider harm reduction measures as a public health strategies by ensuring that non-combustible to cigarettes are properly regulated. This is consistent with the House Resolution number 1885, which was unanimously approved by the House of Representatives here in the Philippines in the year 2018. The said resolution urged the Philippine Department of Health to promote harm reduction measures like the use of electronic cigarettes as part of its national tobacco control strategies. This proposal provides different key things. The first key thing is that it will mandate that minimum age for buying e-cigarettes here in the Philippines, including heated tobacco products, is 18 years old. Retailers are required to verify the age of all buyers by asking for a valid government-issued identification card. Second, it requires graphic health warning on packs of e-cigarettes and HTPs saying that it contains nicotine, which is very highly addictive, and that it is not recommended for non-smokers. We do not know yet the designs of these global health warnings or GHWs. But what is important right now is that these GHWs are different from what are required that are placed on regular cigarettes. Third, the bill provides product standards for this category. For example, it prohibits additives that are carcinogenic in nature, mutagenic, and reprotoxic properties in unburnt form. Fourth, it restricts product communications. Advertisements should not be aimed at particularly to appeal to persons under 18 years of age. This should not undermine quit smoking messages and should not encourage non-tobacco or non-nicotine users or e-cigarette users, HTPs, here in the Philippines. Finally, product communication should not contain any information that is untrue, in particular with regard to product characteristics, health effects, risk emissions, and other risks. As to would say that I'm a medical technologist, what really interests me now to tobacco harm reduction is that I specialize on blood chemistry and urine analysis. I did a research on measuring the biomarkers on Filipino urine and blood and body fluids to associate these risk factors and biomarkers to lung cancer. So this paved way to me to have my interest on doing my field of profession and also doing harm reduction. And this have fused me and give me interest to do research. So in relation to that, is that saying that the harm reduction researchers in the Philippines is still in its pioneer, and we're still at the verge of doing its promising footprints right now. We're one of the, should I say, one of the first Filipino researchers who have pioneered and have paved way in doing strong foundations on harm reduction research in the country on the foundations of clinical chemistry and urinalysis for saying that I'm a medical technologist. So at the
Thank
end
you.
of the day, I think that's all guided by science. And I would like to personally extend my thanks to the Department of Biochemistry and Biotechnology, University of Thessaly, and to the University of Parthas in Greece, which are the esteemed organizer of this event. And this is a very great opportunity for Philippines and Filipino researchers like me to take part in the event and to be recognized as one of the active participants in Asia, especially in Southeast Asia, in advocating and upholding harm reduction through collaborative efforts of sharing academic insights just like this event and doing related researches in public health in general. With this, Efkaristo, thank you, and mabuhay.
Thank you, Ron. Thank you so much. And a big round of applause silently to all the 7 panelists. Really, it's very enriching. We have 2 questions in the chat box forwarded to us from our host. One, Dr. Ferris has answered on the chat box. I'll just recap quickly. One of our friends, Solomon Ratamane, had one question from Ferris about Tunisia. Have e-cigarettes been banned, and are there smoking cessation programs? Ferris, if I understood right, you said e-cigs are not yet regulated but not banned, and smoking cessation programs have existed for a long time. Let me chip in here. In India, unfortunately, e-cigarettes have been banned. And of course, cessation programs have been on for the last 20 years. The other question, my friend Rajesh Sharan, is also from Solomon for you. Why are healthcare providers in India demotivated about harm reduction? Have they been trained in it? Very briefly, Rajesh, my apologies, but very briefly, please, to that.
I think there are multiple reasons. First, thanks a lot for this important question. There are multiple reasons doctors are overworked. Unfortunately, in India, a lot of healthcare professionals are themselves users of tobacco, smoking or smokeless tobacco. So if they themselves use, I think it demotivates them to tell somebody else not to use, because they don't consider it very important. They are also overworked with time. They are not trained at all. In fact, the medical syllabus is very, very differently designed. And one of the solutions to the problem is also to introduce the concept of harm reduction in their medical education system, and tell them specifically how to deal with tobacco cessation, because it's not only a physiological problem, it's also a psychological problem. And so it's a very complex issue. And I think that's the reason primarily.
Thank you, Rajesh. It seems to me that we are already beyond time. And so I just want to add a couple of points very quickly, continuing from what Rajesh was saying. I do think I realized from what everyone was saying, our 7 good friends, is that we are all in the same boat. We are sitting in different parts of the world, but we are figuratively in the same boat of trying to get the society, local societies, and the governments to understand and accept the idea of harm reduction. In general, in medicine, certainly in tobacco control. And so to that extent, we are on the same boat. Besides many other good points that friends made, one that occurs to me from what Rajesh also said, and the last question is, essentially the societies, the governments, and the healthcare professionals, at least in the LMICs, seem to be battling this basic issue of idealism versus pragmatism. And I wish we had more time to discuss that, and Rajesh knows I really love discussing that. But there is this whole issue of idealism, and as one of the panelists mentioned, one of the factors is this godlike self-esteem that doctors and healthcare professionals have. And so that's one problem. The last thing I want to say is that while our friend from Philippines, I think from Malaysia spoke about the new act, I'm sure we'll all agree that while legislation can bring about potentially some change, it's essentially social action that will bring about change. And I want to compliment all 7 of the panelists here, because it's apparent that all these 7 have been in their own nations and in their own regions, making the best of the efforts and actually making some difference. We hope that in the next few years, we'll all collectively make more impact. With apologies to the organizers for overshooting by a minute or 2, I'll take the liberty of handing over, if all of you consent, to the organizers. Thank you.
Thank you.
Thank you.
I'm informed that there's one question.
Oh, if there is, sure. Can I do a, yeah? Okay. Dr. Farsilino, who we know, since a lot of population in India, including healthcare professionals, the users of tobacco, many of them already providing government throughout the country, Swedish match and almost harmless. That's a good question, Farsilino, but a very complicated answer. Cultural, political, professional. I guess we'll have to take it up sometime. But yes, that's one direction. Sure. Oral tobacco is much of a larger problem for us than the actually smoking route. I really am compelled to believe that the organizers would be waiting for us to end this session so that they can go to the next one. Is that correct, sir? I just want to say one more time, what a great pleasure it has been. All 7 of you colleagues, Rajesh, Sharifa, Ron, Efrain, Amaliya, Kgosi, and Ferris.
Thank you.
This is
Nimesh,
Nimesh.
what I just want to say is that
Of course, please.
we are surrounded by a pandemic of truth economy amongst all of us, which is approaching poverty levels. And the danger of that is that it's detrimental to public health and trust of all of us. And we need to ensure that there's accountability for information that gets put out. And the biggest threat to trust of the profession is celebrity status, where researchers go to the public through newspapers before staff has gone through peer-reviewed journals and their peers have expressed opinions on those matters. And we need to ensure that that practice is mitigated against.
I can't but help say.
I mean, I was just wanting to say that, yes, that's a huge problem also in India. And I think it's one of the points that I said, that there is a tacit and very, very obvious, but very tacit, kind of interference of industries with every sphere. And I think that's one impedance that's happening also in India.
Sure. Since the organizers seem to be giving us liberty, I can't but help say to what Kgosi and Rajesh are saying, that Nelson Mandela to Martin Luther King Jr. to Gandhi himself, and Gandhi I know better than the other two, they were possibly the best examples of idealism. And yet, my assertion is that all 3 of them were very pragmatic. What I think the governments, healthcare professionals, and medical doctors need to recognize for harm reduction is to merge and mix the idealism that medical profession carries with pragmatism of what healthcare service delivery is and what's possible and what's not possible. And so my last word, if you permit, will be idealism vis-a-vis pragmatism. I wouldn't even say idealism versus pragmatism. Idealism vis-a-vis pragmatism. Organizers, sir, all yours.